I'm going to talk you through the ECG indices of cardiomyopathy and particularly the things you shouldn't miss. It's quite a lot to talk about in 10 minutes, a whistle-stop tour, but I'm going to leave you with 5 key messages and I'm going to illustrate my talk with practical examples. So we all know that there's a number of causes of sudden cardiac death in young athletes, but worldwide the cardiomyopathies probably account for the largest causes. And one of the features of these conditions is that they have ECG characteristics that can be readily identified by a 12-lead ECG. And this is why a growing number of authorities worldwide are now advocating pre-participation screening, which includes 12-lead ECG in their screening protocols. And finally, in 2017, we received some truly evidence-based guidelines on the interpretation of an athlete's ECG. And it's from these guidelines that I'm going to take you through some of the abnormal ECG findings, specifically those that should raise awareness of a cardiomyopathy. So let's start with T-wave inversion, because and I'm going to spend some time on this because this is an important topic. First of all, how do we define abnormal T-wave inversion? Well, this is a T-wave that's greater than or equal to 1 millimeter in depth in 2 or more contiguous leads, and it excludes leads AVR, 3, and V1, because T-wave inversion can be normal in these leads. Furthermore, we then subdivide T-wave inversion into the territory they occur in. So anterior T-wave inversion V2 to V4, inferior in 2 and AVF, it may or may not involve lead 3 as well. Lateral can be 1 and AVL and or V5 and or V6. So I'll show you some examples of these because some people can sometimes get a bit confused. And finally, obviously, infralateral is a combination of the two. So let's show you some examples. This is quite easy, straightforward. Anterior T-wave inversion limited to V1 to V4. It doesn't have to stretch all the way out to V4 to be classed as anterior. Even if it's in V1 to V3, that's still the same. Moving on, in lateral T-wave inversion, here you can see T-wave inversion in V3 and V4, but note that it extends out into the lateral leads V5 and V6. Note also that there's a small T-wave here in AVL, but this doesn't meet criteria to be abnormal. This is a very similar ECG, but note on this occasion the T-wave inversion is only found in V5. Now, this would still be classed as abnormal. Remember, the guidelines say V5 and or V6. It doesn't have to be present in both V5 and V6 to be classed as abnormal. And when it comes to lateral T-wave inversion, of course, don't forget the other lateral leads, 1 and AVL. Moving on, T-wave inversion can be found isolated in the inferior lead, so here 2 and AVF, including lead 3 in this example. And finally, infralateral T-wave inversion is obviously a combination of the two. So I hope that illustrates the different definitions. So why is this an important thing? So let's move on to look at a case. This is an athlete that was screened, and you can see that apart from T-wave inversion in V2, V3, and V4, he has T-wave inversion extending into the lateral and the inferior leads. When we performed echocardiography, we see that he exhibits asymmetric septal hypertrophy of greater than 15 millimeters with a small LV cavity dimension, and he has abnormal indices of diastolic function. So this individual ended up being diagnosed as having hypertrophic cardiomyopathy. So my first message is, with respect to T-wave inversion, that it is a marker of cardiomyopathy. In the lateral and or in the inferior leads, it should always be considered abnormal, and therefore it should prompt you to perform comprehensive evaluation follow-up, at least an echocardiogram, if not more. So you might ask, what about anterior T-wave inversion? So I'll show you another example. This is a ECG from a 21-year-old Caucasian athlete, and note he exhibits T-wave inversion in V1 to V3 this time. Now, this individual was complaining of pre-syncope and palpitation during exercise, so we put him on the treadmill, and this is what happened. He developed quite a nasty broad complex tachycardia, very suggestive of non-sustained VT. And prior to the exercise test, when we performed echocardiography, we noted that he had a dilated right ventricular outflow tract, as well as possibly the hint of maybe an aneurysm in the right ventricle. And furthermore, cardiac MRI scanning revealed late ganglion enhancement in the right ventricle, as well as involving parts of the left ventricle in a characteristic pattern. And this was highly suggestive of arrhythmogenic right ventricular cardiomyopathy with left ventricular involvement. However, as you've heard in the previous talk, there are a number of determinants of T-wave inversion, and two key determinants are the age and the ethnicity of the individual. And as my colleague Dr. Gatti's pointed out, there's a clear correlation in the literature in prepubertal athletes with increasing age up to the age of 16 and decreasing prevalence of anterior T-wave inversion. So we see this in our day-to-day screening practice, that you'll see an athlete aged 14 with anterior T-wave inversion, normal echo, no symptoms. You screen them 2 years later, and the T-wave inversion is resolved. So this is the juvenile pattern. So this is one caveat. And the other one is this landmark study by Michael Papadakis, which showed that up to a quarter of black athletes exhibit T-wave inversion, which is normally confined to the anterior leads, as we've seen in a characteristic pattern, usually preceded by convex ST segment elevation, and this is now regarded as a normal ethnic variant. So back to my message about T-wave inversion, when it comes to anterior T-wave inversion, this should be regarded as abnormal beyond V2 in postpubertal athletes over the age of 16 and non-black athletes. So that's my first message about T-wave inversion. Let's move on to look at ST depression and another example. This 29-year-old athlete exhibits pathological ST depression defined as ST depression of greater than or equal to 0.5 millimeters in depth in 2 or more contiguous leads. And when we performed echo and MRI on this individual, he exhibited clear hypertrophy of the apical segments with apical cavity obliteration and was subsequently diagnosed with apical hypertrophic cardiomyopathy. So my second message is about ST segment depression. This is a marker of cardiomyopathy, usually hypertrophic cardiomyopathy, but it can be found in other heart muscle disorders, and it should always be considered abnormal in an athlete and prompt comprehensive evaluation and follow-up. Moving on, and pathological Q-Waves. Now, these can cause a little bit of confusion. In some cases, they're completely obvious. I don't think anyone would argue that this individual exhibits Q-Waves in V1 and V2. But in some cases, it may be a bit more subtle. So if we look at this ECG and you concentrate on leads V5 and V6, this individual also has pathological Q-Waves. So how do we define these? So pathological Q-wave is a Q-wave that is greater than or equal to 25% of the ensuing R-wave. So the QR ratio is greater than or equal to 0.25. They're greater than or equal to 0.40 milliseconds in duration and occur in 2 or more leads. So that's our definition. So if you contrast this ECG with the next one I'm going to show you, this individual also exhibits Q-waves, but if we look closely, these do not meet our diagnostic criteria. So they don't meet that criteria. So when it comes to pathological Q-waves, yes, these should be regarded as abnormal and they are markers of cardiomyopathy, but you have to remember to interpret and measure them correctly. And if indeed you do find a pathological Q-wave, this again should always be considered abnormal until proven otherwise and prompt comprehensive evaluation and follow-up. Moving on to left bundle branch block. This is a 30-year-old cyclist who'd noted a reduction in his exercise tolerance. And all of you probably recognize this clearly as a left bundle branch block pattern, but the official definition is of a QRS duration which is greater than or equal to 120 milliseconds. There is a predominantly negative QRS complex in V1 with an upright or slurred R wave in 1 and V6. So we performed further investigations on this individual, and his cardiac MRI scan showed clear features of the left bundle branch block in terms of dysynchrony. He also had increased indexed left ventricular end diastolic volumes and a reduction in LV function, and was diagnosed with a dilated cardiomyopathy. So my fourth message is about left bundle branch block. Again, this is a marker, can be a marker of cardiomyopathy, and it should always be considered abnormal until proven otherwise, and it requires further investigation and follow-up. Okay, so in the final few minutes of the talk, I'll just talk you through a few other electrical changes as markers of cardiomyopathy. This is another ECG, real case, 17-year-old young athlete, syncope during football. And I think all of you will agree this is a highly abnormal ECG. If you look, there's very large complexes throughout the anterior chest leads, but also associated with resting ST depression and T-wave inversion. However, if you look very closely, you also see other abnormalities. This individual has a very short PR interval, and if you look closely, there's also a slurred upstroke to the QRS complex. In other words, a delta wave suggestive of ventricular pre-excitation. And when we performed echocardiography on this individual, he had global left ventricular hypertrophy, which appeared very suggestive of an infiltrative disorder. Actually, this individual ended up being diagnosed with a glycogen storage disorder due to a mutation in the PRACAG2 gene, which can cause a phenocopy of HCM. And the final case is of a 33-year-old athlete who presented with dizziness and pre-syncope. He also complained of palpitation and a decrease in exercise tolerance. And if we look at his ECG, there were multiple ventricular ectopics, here in a trigeminal pattern, but the key thing is that there were greater than or equal to 2 ventricular ectopics on his ECG. And when we performed a Holter monitor because of his symptoms, we found that there was a long 6-second pause due to Mobitz type 2 AV block. And echocardiography on this individual, now this is a little bit subtle, but it revealed a reduction in his ejection fraction to around 45%, and importantly, this did not improve on exercise echocardiography. Now, this individual also mentioned to us that he had a family history of multiple family members having pacemakers at early ages and being told they had a weak heart. And this was highly suggestive of a mutation in the lamin AC gene, which produces a dilated cardiomyopathy phenotype with conduction disorder. And indeed, he did have a positive mutation in this gene. So my fifth and final message is that there are other associations with cardiomyopathy. Pre-excitation can give you a HCM-type phenotype and should prompt echocardiography if it's observed on the ECG. Mobitz type 2 and third-degree AV block are also associated with cardiomyopathy and should again prompt echocardiography as a minimum. And finally, multiple ventricular ectopics can also be markers of an underlying heart muscle disorder. So I think I've run out of time. I'll stop there, but I'll leave you with my 5 key messages. Thanks for your attention.